This talk is going to be about a patient who has had complications from an artificial joint placement in her temporal mandibular joints. And I'm going to ask Brian to give a brief history on how she presented to our clinic this week.
So this was a young lady that presented to the office with a chief complaint of inability to reproduce her bite. In other words, a mandibular dystonia after receiving total prosthetic joints approximately 3 months prior. She had some pain involved with this post-operative period, but for the most part her complaints were the dystonia.
And just to give everybody an idea of what a total joint looks like, let me draw your attention to this slide of 3 different images of this patient. And you can see the metal prostheses on each side of the mandible, and there are 2 components to each side. The first is actually a ramal implant that's screwed into the ramus of the mandible, and the second is a fossa liner prosthesis up here screwed into the upper part of the temporal mandibular joint. And as you can see, she has one of these on each side, although the positioning is a little bit different. If you look at the right side, for example, the condylar prosthesis is closer to the ear canal and kind of in the fossa or indentation of the upper liner, whereas this condyle on the patient's left side is sitting forward. So what that does, because of that positioning of the mandible, it's making her bite into what's called a cross bite. And the cross bite looks like this. The teeth on the right side have crossed over, so the bottom teeth are outside the top teeth. And her dystonia, or abnormal muscle tone, is what's making her bite in this particular type of alignment. And here's a picture of us trying to get her to bite more normally. And you can see there's actually distortion in the way the teeth line up. So when she tries to center her jaw, first of all, that's very difficult for her to do because of the dystonia. But also her teeth just simply don't match. And you want to talk about her profile a little bit?
Yeah, sure. So we're looking at her from the side, which is what we call a profile view. One side is the right, the other is the left. And if you look closely, you can see that there is some asymmetry between the position of the upper prosthetic component and the lower prosthetic component. On the patient's left side, the condylar portion of the prosthesis is forward or anterior, and on the patient's right side, it's sitting in a more concentric or centered position.
And we're not here to imply that anything irregular was done at the time of surgery. In fact, the patient noted right after surgery that the jaw was pulling off center a little bit, and so she was placed into elastics to try to make the bite fit better. And then this was followed by more and more distortion or dystonia over the next several weeks. And so she's had injections and various things done to try to get the muscle to release. But it's kind of an interesting background when you look at how muscles actually control and move the jaw structure. So this is another image of the prostheses on the right side. And over here you can see the liner on the skull base up in here. This is actually the ear canal. And so this is the side of the jaw. And you can see the screws that are holding the prostheses into the underlying bone. And we're going to turn this to look at it from the front. And that's this picture right here. So here's the condylar prostheses and the fossa. And then we're going to turn it to look at the inside because that really shows a lot of the anatomy. So the prostheses is now sticking up here. That's the condylar part. And if you look at the inside part of the mandible, it slopes back like this. And there actually was a bone structure that stuck up here originally called the condyle. And the condyle is where the muscle attaches that normally moves the jaw structure.
So in this rendering, we're looking up towards the temporomandibular joint on the left side of the patient. The joint itself is padded by the disc you can see in sort of an orange-yellow color with the two bony components. There are muscles that attach to the lower jaw and to the skull base that allow the mandible to move. The most important of these muscles with lateral movement and protrusive movement is what we call the lateral pterygoid, and it's composed of a superior and an inferior head, both of which we can see on this diagram.
So what happens during a total joint replacement is an amputation of the bone right here. And so the condyle is totally cut free. And what happens typically then is the muscle is just kind of free in space. It doesn't attach to the bone. What we don't know, because we didn't have the original operative note, was whether or not these muscles were reattached somehow to the remaining bone or somehow wrapped to the prostheses. So typically, when the jaw is moving sideways, like this patient does, it's these muscles right here that make that movement. But assuming that they're not working normally or that they're detached, seemingly the dystonia or abnormal muscle movements have to be coming from somewhere else. So again, here is the anatomy looking at the computer model from the inside of the jawline, and you can see the original condyle with muscle attached. Since that's amputated here, as you see in the patient's actual CT scan, that muscle can no longer be active. Instead, there are accessory muscles that are sometimes used to move the jaw, and that probably is where the dystonia is coming from.
And if we look at the rendering again, the computer model, from this position, we've tried to mimic the patient's malocclusion, with the scissor bite being on the side you can see, and the cross bite would be on the opposite side. If we look below the lower jaw, we can see the suprahyoid and digastric musculature that has probably taken over the patient's jaw movements since the lateral pterygoids have been amputated.
So it's a pretty interesting situation. When a patient develops dystonia, it sometimes is difficult to know why that happens. And quite typically, these things can occur spontaneously, and we start looking for lesions in the brain. However, after a surgical procedure where nothing was done to the brain, you might think, well, this is coming from the periphery in the body, and there aren't too many things that can create a dystonia, but one is a condition called complex regional pain syndrome. Like Brian said earlier, this patient didn't have a lot of pain, she had some, and so she wouldn't really be a strong match for the pain part of the syndrome. But another big thing that happens with CRPS is muscle dystonia. And so the muscles that cross a joint or move a joint get into an intense amount of spasm, and very frequently that'll distort a joint. If it happens in the hand, you can get drawing of the hand like this. You can get stiffness in the shoulder and the elbow, and certainly this type of thing can restrict movement of the jaw itself. So our thought was, well, this could be dystonia from CRPS, and so we then gave the patient a couple of diagnostic nerve blocks.
And interestingly, we saw some decrease in muscle fasciculation on one of the sides where we did the nerve blocks. It didn't remove her dystonia in that we couldn't reproduce a normal occlusion, but the fasciculation seemed to resolve almost completely on one side.
So what we did, we blocked the cervical plexus, and that's a nerve that comes out of the side of the neck, and it innervates across the front of the neck and along the side of the face and down to the shoulders. So we selectively blocked the cervical plexus on her left side. Now, the nerves that are contained in the cervical plexus are of two different types. One is a sensory nerve, the other is what's called an autonomic nerve or a sympathetic nerve. And it's the sympathetic nerves that can cause Cribs-related dystonias. And so the fasciculations or appearance that there were a lot of spasms going on in the jaw, we could see that visibly reduce on her left side when the block was given. So from that, it kind of led us to thinking that this is not a mechanical abnormality with the prostheses, and it's more likely a neurological problem from the sympathetic nerves that are overly active. And so we held discussion with the patient about a couple of options that she could look into for management.
And, we talked a little bit about nerve stabilizing medications like Lyrica or Neurontin. And we've also brought up the concept of IV ketamine, which may be another option that could be useful for this particular patient.
And we'll have other presentations that specifically address treating CRPS type 1. So we'd like to leave a couple of messages with our viewers about different parts of this case. This was a young woman. She was in her mid-20s. And so one bit of advice that we would give is to ask lots of questions about the kinds of things that can become complications from having an artificial joint. This is certainly something that's extremely unusual. And again, we're not finding any fault with the surgeon or the surgery itself, but this is a complication that can occur, and it's a little difficult to overcome because with the original condyles cut away, it's really not a great option to remove the prostheses because then nothing is in there. And that's where we sometimes have to go to options like a rib graft, which again is not simple. So I think certainly asking questions up front, can things happen? Can there be complications? That's the type of thing that patients have to ask. And at this particular point in time, really the key consideration is, well, how do you go about treating and fixing this kind of thing? And a lot of times the dental profession focuses on bite treatments, but I'll have you comment on the validity of what that may do or not do.
Yeah, and one of the things the patient mentioned to us was one of the doctors she had seen is considering doing orthodontics or splint therapy to fix her occlusion. The problem with that is that it's not addressing the underlying cause, which is the dystonia. Sort of taking a malocclusion like this and trying to forcefully place it into the correct position could be detrimental to the dentition and probably isn't going to be useful. It would be like trying to contain a muscle spasm with braces, which is probably not useful.
And she actually had a splint that was placed against her teeth, and it had a certain bite position built into it to try to encourage her to bite a certain way, but she just simply couldn't do it. The dystonia was too complicated. Another kind of key thing here is that stimulation will tend to make this condition worse. And one major stimulant to sympathetic nerves is tooth movement or certain types of dental treatment like root canals. And so that can kind of make it complicated. And there was one last cofactor that we picked up in the patient actually at the very end of the consultation. And that was that she's a nicotine user. And nicotine can be particularly problematic in muscle dystonias because it creates a hypoxic state or decreased oxygenation of muscles and typically is major input into potential pain. So anyway, kind of a complicated, interesting case.
Very interesting.
And we hope that this presentation gives our viewers some insight into what we call dystonia after placement of a total joint prosthesis.